State President, IAP State President Jayaraman Sir, IAP State President-elect Dr. Vijay Kumar, Senior faculty like CK Sir, VK Parvati Madam, HOD Pediatrics, Calicut Medical Coach, Dr. Ajit Kumar. So I would like to welcome each and every person here. And today the topic, the panel discussion is moderated by Dr. Abdul Rauf KK. He is the pediatric intensivist at Baby Memorial Hospital, Calicut. He has got more than 20 publications to his credit. And he received the Young Talent Award by Indian Society of Critical Care Medicine in 2020. And more important is he, for IAP, he is very instrumental in bringing out our journal of our Calicut IAP. So I would like to welcome Dr. Abdul Rauf to moderate this session. And the panelists are Dr. Jayakrishnan MP. He is additional professor of pediatrics, and he is in charge of our pediatric intensive care unit at IMCH. And he has got several publications, especially he is a world authority on long QT syndrome. He has got publications in prestigious journals on that topic and also on snake bite. So I welcome Dr. Jayakrishnan to this session, and Dr. Satish Kumar, he is senior consultant, pediatric intensivist at Aster MIMS Calicut. He is very active in IAP. I would like to welcome Dr. Satish Kumar also. And we have Dr. Suma Balan. She is well known to all of us, professor and pediatric rheumatologist, Department of Rheumatology and Clinical Immunology, AIMS Kochi. I had a short period in AIMS in genetics department, and I had the occasion to meet her a few times and discuss certain cases. I would like to welcome Dr. Suma Balan also to this as a panelist here. So without spending much time in other activities, we would straight away go to the panel discussion, and we have discussions at the end. So Dr. Rauf, you can start the session.
Thank you, sir. Respected senior pediatricians, IAP office bearers, and esteemed members of the panel, and dear members of the audience, good evening to one and all. So, our plan is to have a short introduction, then we move to the panel discussion, and if time permits, we will take up questions from the audience. So, during the initial phase of the pandemic, that is during the first few months of 2020, pediatricians were a bit relaxed because the children were getting very mild infections by the SARS coronavirus, and hardly any children were becoming critical, and hardly any children were dying. There was hardly any mortality. But during the late weeks of April and the initial May, that is 1 to 2 months of onset of, or 1 to 2 months after the peak of pandemic in few countries, clinicians were perplexed with the presentation of children who presented with a peculiar illness which had some features of Kawasaki disease, and or many of them had shock. So the first of these reports came from the United Kingdom, and subsequently there were reports from France, USA, and there were reports from the countries like Italy. So this prompted the UK NHS to issue an alert in respect of children and pediatric shock in the last week of April. So these children had abdominal pain, gastrointestinal symptoms, they presented with shock, they had evidence of myocarditis, and they had overlapping phases of toxic shock syndrome and Kawasaki disease. So the RCPCH, they called this illness as pediatric multisystem inflammatory syndrome, temporarily associated with COVID-19, and subsequently the WHO called it multisystem inflammatory syndrome in children and adolescents, temporarily related to COVID-19, and CDC called it as multisystem inflammatory syndrome in children, that is MIS-C, the term which is very familiar to all of us now, associated with coronavirus disease 2019. So this is one of the very first papers published on this topic. This is a study from published in Lancet in May 2020. So they noticed a 30-fold increase in the incidence of Kawasaki-like disease after the onset of coronavirus pandemic compared to the previous years. So this paper gave a warning that a similar outbreak of Kawasaki-like disease is expected in countries involved in the SARS-CoV-2 epidemic. So we all know what happened later is history. So during almost the same time, in the last week of April, we had a patient who was a 5-year-old boy who presented with acute febrile illness, had abdominal complaints. He was referred as a case of acute abdomen for laparotomy. On examination, had redness of conjunctiva, extremity edema, sterile pyuria. He had lymphopenia, elevated inflammatory markers, liver enzymes, acute kidney injury, and he presented in shock. And he had a suspected SARS-CoV-2 contact. So this patient, he was a febrile illness with multi-system involvement. We managed him initially as a typical disease with symptomatic myocarditis. So we treated him with IVIG, steroids, and supportive treatment. And during the course of this illness, while this patient was admitted in hospital, this alert from UK came. So we published this, and I am humbled to say that ours was the first published report of multisystem inflammatory syndrome from an Asian country. And our report has been subsequently cited by more than 50 articles. So afterwards, in the months of June, July, and August, there were many reports of cases of MIS from India, from different, especially from the metro cities like Delhi, Kolkata, Chennai, Mumbai, and all. And in Kerala, probably because we delayed the peak of COVID-2 pandemic, our peak of MIS-C was also delayed. And over the past 4 to 5 months, across Kerala, everywhere there are cases being reported. So our experience in last few months, so in total we have seen 14 patients, and the median age is 8 years, and 80%, almost 80% had abdominal complaints, and more than 50% were in shock, and more than 1/3 had myocarditis or a decreased EF. And coronary dilatation was present only in 1 patient. 8 patients needed inotropic support, and almost 80% needed some amount of respiratory support. Only 1 patient needed invasive ventilation. And PCR was SARS-CoV-2 PCR was negative in all patients, and we could do antibody only in the 9 patients, initial 5 patients, because of the lack of testing we couldn't do. And in the last 9 patients where we could do antibody, all were positive, and there was no mortality. So with this background, we move to the discussion. So MIS-C, the case definition has been given by WHO and subsequently by the CDC. So Jagakrishnan sir, can you please describe the WHO case definition, and you may also highlight the difference between CDC and WHO criteria.
Thank you, Rao. Can you hear me, Rao?
Yes, sir.
Yes, sir. Yes, sir.
Good evening, friends. And my thanks to the leaders of our vibrant Kozhikode branch for arranging this meeting and inviting me. And now, as Dr. Rauf mentioned, this condition, that is MIS-C, that is multisystem inflammatory syndrome in children, is I mean, we need to consider that in any child presenting with fever and multi-organ involvement with features of inflammation, and if there is no other alternative diagnosis to be considered. There have been multiple definitions, as mentioned by Dr. Rauf, starting from the definition that was given by RCP, Royal College of Physicians, UK. Then there was this definition by CDC US, and then WHO has also come up with the definition. And what is common in all these definitions is any child presenting with persistent fever, with multi-system involvement, elevated inflammatory markers, and if there is a link, epidemiological link to SARS-CoV virus infection, and with no alternative diagnosis considered. Rauf, can I change the slide now? And the picture that I have given there was taken from the CDC website, which shows inflammation involving all organs and also elevated inflammatory markers. And what is given by WHO is this, that the age group they have given us less than 19 years, with fever lasting more than or equal to 3 days, and it features of clinical, clinical signs for multi-system involvement with elevated markers of inflammation. And a very important thing is that no other obvious cause for inflammation should be there, and there is evidence of SARS-CoV-2 infection in the child. So that's the definition. Can you go to the next slide? And regarding this multi-system involvement, out of these 5 mentioned, at least 2 should be there. That is rash, conjunctivitis, mucocutaneous inflammation, shock, cardiac involvement, coagulopathy, and acute GI symptoms. We'll come to all these later as we discuss the cases. As we discuss the clinical features and all that. And elevated markers of inflammation like elevated ESR, CRP, or procalcitonin. Okay. Next slide. CDC, there's a slight change in the age. They have mentioned that it is less than 21 years. And another important change is the duration of fever, that they have mentioned is more than 24 hours, just 1 day fever. And I think as far as the experience that we have now in Calicut, we know that any child presenting with fever lasting for more than 1 day itself should be considered for the diagnosis of Mis-C if there are features of multi-organ involvement and inflammation features, because it's vital that you make a diagnosis early. But then what is, I think, easy to remember and practical for all pediatricians is the WHO definition. But the only thing I think is this duration of fever. We can, I think, consider Mis-C even in children who have fever lasting for more than 1 day. And the last criterion, that is possible, recent or current SARS-CoV-2 infection or exposure is also may not be very much relevant in our setting now, because in Kerala, we know in Kozhikode now, it's more than 10-11% now, the test positivity rate, and likely contact is there for all practical purposes for all of us, I think. So any child presenting with fever, features of multi-organ involvement, inflammation, and we have no other obvious reason for any other diagnosis, I think it's better that you make a diagnosis of Mis-C and treat it, because early treatment makes a big difference. Because this can be a potentially lethal condition if you're not recognizing it early, and if not recognizing it early and start the appropriate treatment. Thank you, Rao.
Thank you. So now moving to the clinical and laboratory features. So for last few months, there is now enough data available. There are series of large number of patients. So Sadish sir, so based upon the available evidence, can you describe about the clinical and laboratory features of MIS-C? Sadish sir is muted.
Yeah. Can you hear me now?
Yes, sir. Yes, sir.
Okay. Sorry. Thank you, Rof. So I think as Jackson sir told, I think we at this point of time have a kind of a picture with us when we would suspect patients have multisystem inflammatory syndrome. And whatever data we have, I think this is from basically from what Rauf has shared to us as is a systematic review of somewhere around, I think, 600, 700 patients odd. And there are multiple reviews like that. And most of them, all of them, I think all of them kind of have a common picture. If you, whether the data is from US or from UK or our own data, we would suspect somebody is having multi-system inflammatory syndrome in this scenario. If a child is presenting with a high-grade fever, even if it is, let us say, for more than 1 or 2 days, and this is consistent across all patients. It's there in about 100% of patients. That's what, literally 100% of patients. And there is some data which says maybe a few of them did not have fever, but most of them have fever. And another common presentation is those having presenting with abdominal pain, vomiting, and diarrhea. If you take abdominal pain, vomiting, and diarrhea together, it somewhere comes to around 80%. So somebody has high-grade fever and abdominal symptoms, it kind of points towards MIS-C in this situation. In addition, about 70% of them have an erythematous rash, which kind of waxes and veins, and kind of a non-purulent conjunctivitis or a conjunctival injection, basically. So if all these three are put together, and if somebody has kind of all these symptoms, we kind of have should have a very strong suspicion of MIS-C in these patients. High-grade fever, abdominal symptoms, and an erythematous rash with a conjunctival injection is something which we should think about MIS-C in this situation. So the other things which, when we examine the patients, we find some clinical features or the clinical presentations apart from the febrile illness. And we are talking about the sick children, where if you find about 50 to 60% of them present with shock, and about a reasonable, about half of them, about 30% of them have about LV dysfunction with CCF. A small proportion do have features of meningeal irritation, about 20%, with neck stiffness and bit of lethargy. And kind of when we do, some of them have had LP done, we find a picture of aseptic meningitis in these children. And an evidence of serositis with pleural, pericardial, and effusion and ascites in about 30% of these children. So clinical features predominantly, which concerning features or complications, as we can say, is shock in about 60%, and LV dysfunction in about 30%. Other incidence of meningoencephalitis 20% and serositis 30%. About 20-25% do have some respiratory symptoms also. Is there next slide? Oh.
Yes, sir.
Thank you. So coming to the laboratory features, I think the very strong pointer, which we now consider kind of a strong indicator for MIS-C, is a very, what is called an hyperinflammatory state, wherein we find a very highly elevated CRP and also other acute phase reactants. So if you look at the hemogram, you find leukopenia with lymphopenia, where very high elevated CRP, which is usually in tune of somewhere around 200 to 250, but not necessarily everybody has that high CRP. So, but most of them have kind of around 100 to 200 is what we have been generally seeing. So leukopenia, lymphopenia with a highly elevated CRP of 100 to 200. And some patients have some amount of thrombocytopenia also. This picture, kind of, if you see the counts, which are kind of viral, but then there's a significantly elevated CRP. So this kind of picture is pointing towards MIS-C. And we also have coagulation abnormalities. We have abnormalities in PT, APTT, and also an elevated D dimer, which we see kind of literally all patients have elevated D dimer and fibrinogen. So as I said, about 50 to 60% have cardiac abnormalities, which could be either LV dysfunction or it could be the abnormalities on the blood tests, which indicates some form of myocarditis. There's elevated troponin or features of a CCF with increased BNP. On echo, there will be LV dysfunction. And in a certain percentage of patients, you do find some coronary artery abnormalities or dilatation. Coming to as Sir was telling about the correlation with COVID-19 testing. As per the literature, it is about 25% are PCR positive, about 50% are antibody positive, and an additional 20% are positive for both. This is only 25% only PCR positive, negative for antibody, 50% positive for antibody and negative for the PCR, and about 20% are kind of positive for both. And what we have been seeing is, I think most of them have antibody positive. PCR is very minimal, basically about 20% of them have PCR positive. So in terms of laboratory features, you find a viral picture in the hemogram, leukopenia, lymphopenia, with a significantly elevated CRP. Abnormalities in the D dimer is what pushes you towards the diagnosis of MASC in a patient who has a very high fever and kind of a rash in abdominal symptoms.
Thank you, sir.
Thank you.
Thank you, sir. So even the etiology of Kawasaki disease continues to be an enigma. So Dr. Suma, can you enlighten us about the proposed pathogenesis or the immunology behind multisystemic syndrome and how Mis-C is different from Kawasaki disease clinically?
Thank you. The thing is, as you said, if you want to put the pathogenesis in just one line, it is immune dysregulation. That's actually a very big umbrella and it covers so many different processes. So it could be that the host antigens are being recognized as similar to the antigens of the bug itself, and therefore you're having like autoantibodies forming, a form of molecular mimicry. It could be that so this could be something that happens through the B cell pathway. Then you could have T cell induced recognition of viral antigens expressed on the infected cells, and that triggers off another pathway. You could have an immune complex mediated inflammation. Now, none of these mechanisms are exclusive to COVID-19. We've seen this with Mycoplasma, we've seen this with Streptococcus, we've seen other bugs that have also done this. But I guess it's a pandemic, the thing that is here, and this particular bug seems really, really good at activating various immune pathways in the body. And also the viral superantigen pathway, which is another cause for the pathogenesis that we see here. Then there's a superantigen form, it's just going to create a very, very high level of cytokines in the body, and that leads to hyperinflammation. So what is the difference between KD and Mis-C patients? Why don't we just say that we're seeing more KD triggered by COVID-19? That's because these children they look a little bit like KD, but they are not really KD. They have some incomplete KD features, but overall, Mis-C tends to involve more of older children and adolescents than infants and younger children who commonly present more with KD. I think in India, we are seeing more younger children with Mis-C than they have seen in the West. But even then, the number of children with this incomplete KD that we see in older children is something that's quite, typical of Mis-C. In the Western literature, they've reported that the more colored the patient, the higher the chance of getting Mis-C. Which is, whereas in KD, Asian patients have the highest risk of KD overall in the world. GI symptoms are very unusual in Mis-C patients, but very common. Very unusual in KD, but very common in Mis-C patients. Similarly, the presentation of shock. KD shock syndrome is known, but it's hardly 5% of KD presentation. Whereas with MIS-C, we have quite a good number of them coming with shock. Similarly, look at the blood tests. In KD, we are used to seeing extremely high white counts and extremely high platelets. But in MIS-C, what you tend to see is lymphopenia, leukopenia, lymphopenia, thrombocytopenia. That's what we tend to see more commonly. And what about the coronary artery aneurysm risk? A patient who presents with shock in Kawasaki disease has an extremely high risk of aneurysms, more even than the typical KD. Whereas in MIS, the risk is more or less equal to what we are seeing to generally KD. So that's the
Thank you,
thing.
ma'am.
It's not exactly the same thing, though there are some similarities. Yes.
Thank you, ma'am. So as we discussed, this MIS children are sicker compared to the classical Kawasaki disease. So, Jackson sir, can you please enlighten us about the priorities or considerations when we get a call that a child with MIC or a suspected MIS child has come presented in the emergencies? What are your priorities and what are your emergency considerations?
Okay, Rav. Now, if you look at the literature, you can see that there is a small subset of patients with mild presentation of MIS-C who may not require hospitalization, who can be managed on an outpatient basis, provided you can monitor these children for worsening of their vitals or worsening of their symptoms and then be immediately brought to the hospital. But considering the social scenario that we have in our country, I don't think that's a practical option, given the kind of presentation that these children can have. We had children presenting, walking to the hospital, smiling, talking, but then having fever and some rash, and then very rapidly developing features of hypotensive shock. So it's not predictable, and it's not very practical for us to monitor these children in their homes. So I think what I would advise is that you admit the child if you suspect MIS-C always. If you clinically suspect, like any child presenting with fever, and something to suggest multi-organ involvement or a rash, and then if you feel that there is other system involvement, better to admit. And where to admit depends on the type of monitoring that you can provide. Like you can maybe admit the child in the ward or in a place where frequent monitoring is possible, like a high dependency unit. If you feel that there is involvement of multiple organ system involvement, or if there are comorbid conditions, like for example, a child having severe asthma, or a child who is obese, or a child who has an immune deficiency disorder, or some other underlying problem, or a leukemia, it's better that the child is admitted in a high dependency unit where you can actually monitor the child frequently. And PICU admission you consider when the child has features of hemodynamic instability, respiratory compromise, like any other unstable child, or any other potentially life-threatening complications, like for example, a child having seizures or an altered sensory, you would definitely admit the child in the PICU. So, can you go to the next slide? And it's very important that you have your infection control measures in place, because and that we do even otherwise now. For any child who's getting admitted in the hospital, we do that because these children we know are potentially in or were potentially in contact with a COVID positive case. That is for sure. And it's very likely that either the child or the caretaker is infectious to others. So it's very important that you take all the infection control measures, and immediate treatment is given based on the kind of presentation that the child has. Can you go to the next slide, Rav? Rav? Next slide.
Yes, sir.
Yeah, okay. So this is what I said, screening for COVID. What we do in our PICU is that we screen all of them with rapid antigen test, and also the caretaker rapid antigen test, and also take sample for throat swab for RT-PCR. And usually by next day, the RT-PCR result is obtained. And if that is also positive, we will transfer the child to the isolation area where COVID positive patients are treated. And very important that you provide adequate universal source control in the form of maybe providing a mask to the patient and also the caretaker, so that they are not I mean, at least the risk of infection to others is minimized. And obviously, appropriate PPE is very important for all the caretakers. Next slide. I think it's over, I think. Rauf?
Yes, sir. I'm set.
Can you go to the next slide? Yes, yeah. So initial stabilization of cardiorespiratory status is like any other sick child. You would treat, I mean, you know the ABC of the initial impression, all the exactly the same way you would treat a critically ill child, your ABC, your primary assessment and all that. And but very important thing to consider is an alternative diagnosis always, because you know the child has fever, multi-system involvement, features of inflammation, but this can happen in many other conditions also. Like for example, a child having an infection like rickets cell infection having multi-organ involvement, or a child having a toxic shock syndrome with shock and rash all over the body, or a child having systemic onset JIA presenting with fever and rash, and could be anything like. But then the initial management is the same, and I think it's better that you don't miss the diagnosis rather than having a misdiagnosis, because misdiagnosis is okay, I think, in this situation, because if you delay treatment, it can be sometimes fatal. Like, so misdiagnosis is okay, or overdiagnosis is okay. Only thing is that you should miss the diagnosis. That's what I would tell. So,
thank you, sir. Yeah. So we move to the next part. So when you suspect MIS-C, so what are the investigations you order? And what are the importance of CRP, ferritin, D-dimer, etc.? So Sadish, sir.
Sorry.
Dr. Sadish is muted.
Yeah, sorry. So there is a big list of investigations being recommended. And in a sick child, yes, probably we may have to do all these investigations at least once to know what is the amount of inflammation, what is the organ system involved, etc. So if you look at these investigations, it's kind of tuned towards one, look for inflammation or hyperinflammatory state, look for involvement of the cardiac system, look for the involvement of the coagulation, and look for an evidence for COVID-19 etiology. So CBC, CRP, serum ferritin, ESR, and I think I missed the procalcitone in there. And that will be the hyperinflammatory kind of investigations. You do a PT, APTT, INR, fibrinogen, and D-dimer levels for the abnormalities in the coagulation. You do a troponin I, a BNP or NT-proBNP, and an ECG and echo for looking for any cardiac involvement. And do a COVID-19 PCR and serology to look for the relation to for a surrogate evidence for COVID-19 infection. So, but then if we have a child who just has fever and some rash, otherwise stable, so we would probably need to do a kind of investigations which is going to help us in the diagnosis, point us towards some treatments which we need to do. Let's say CBC, CRP to help us in the diagnosis, or give additional kind of additional information for diagnosis, and D-dimer to know whether there is a coagulation risk we need to treat or not, and to look at there is evidence of myocarditis, or is this child going to develop any form of coronary problems or myocardial dysfunction during an echo and a tropi. This would be the basic minimum in a stable child who looks like MASC, the CBC, CRP, these things. But then, as Jagdishan sir rightly said, this is something which we are seeing now. But then, at any other point of time, we would consider multiple other diagnoses, which could be a toxic shock syndrome, which could be Kawasaki's disease, which could be any viral or bacterial sepsis. So we should make sure that we don't forget to do blood culture, urine culture, dengue, Rocky Mountain spotted fever, depending on the clinical picture and where you are. So these investigations should be done, and I think we should probably treat appropriately for these suspected infections, like with antibiotics for a sepsis or for a Rocky Mountain spotted fever. I think should also be done. But then when you ask me what I do in terms of investigations, so we would have to kind of consider the cost issues. So we would probably do CBC, CRP. I think the ESR also won't be there. So ferritin maybe once, and after that, that also won't be there. So SGPT, SDOT, urea creatinine, a PT-INR and a D-dimer, a troponin I, and the rest others. So because the BNP, pro-BNP does not give me much more help for treating the child. So D-dimer fibrinogen 1 would be enough for me. This is what we do. There may be differences of opinion, but then there is always the issue of cost also.
Okay, thank you, sir. So in a private setup, we have to do the investigations judiciously or in any setup. Okay. So about IL-6 levels,
yeah,
sir?
Yeah, I think we have not done for any of these patients. We have the facility to do it. But then I think unless the patient is refractory to the first line, second line, and we are going to use kind of, let's say, the third line drugs or immunomodulation, probably then we may need these investigations to help us guide therapy. Probably.
Okay. So Dr. Suma, any comments about doing the IL-6 levels?
The point is, IL-6 levels in the blood do not necessarily correlate with IL-6 levels in the tissues. So you might be on a false footing there. The other thing I think is CRP is an extremely good surrogate marker for IL-6. And if your IL-6 level is high, your CRP will usually be very high. And so that's actually more or less a very, very good surrogate marker. I have not done IL-1 or IL-6 levels in any of my patients so far. I think the point comes maybe when you have a patient who you have treated but is not improving after all the first line treatments are over, the patient is still not responding, and you might be considering biological use. Sometimes you may want to think about doing an IL-6 level. That's about the only time. The frustration of doing an IL-1 level is that even if you find that it's high, you do not have anti-IL-1 inhibitor drugs accessible to us in India to start using immediately on the patient. So I don't mind if you don't do these regularly.
So next, we move to the management part. So Suma madam, so how do you treat, or what are the treatment options for MIAC from a rheumatologist perspective?
So I think what I would like to say is what the others have kind of delineated so far, what Dr. Jayakrishan said about the first steps of identifying the possibility of MIS-C, keeping the patient in the safest place. So if they need ICU, a good number of them need ICU care, and they could be borderline or going into shock. Quite early on, get good IV access. Every one of them you would start IV antibiotics on till your cultures come back. So keeping the basics right is very important, and very, very good supportive care. So managing the hemodynamic state and treating all the extra things is very, very important. Now, beyond that, look at the clinical problem you're dealing with. Are you dealing with a child who is a MIS-C overlapping with acute COVID? In which case, and especially if the MIS-C part, the clinical phenotype is more like an incomplete KD. In that case, the first line would be to give IVIG and to also consider giving antivirals like remdesivir to the child. You see, sometimes, though we usually say that MIS-C, the onset of MIS-C is 2 to 3 weeks after the infection has passed, it sometimes can set off towards the tail end of the infection when the children are still PCR positive. So in those cases, this is what you need to do. But if you have a child in whom merely your antibody is positive, or the story of COVID was much in the past, then, and if the child again has mainly KD type features, IVIG, low dose aspirin. When I said aspirin, I mean low dose aspirin, and consider additional steroids for these patients if this is not enough to improve the situation. Then, if however your child is a shock predominant clinical phenotype, myocarditis and shock with some features of KD, then in these patients you have to use steroids upfront along with your IVIG. In fact, in many of these patients, usually you see this kind of a presentation in the older children. And many of these patients, we have got away with only steroids. We have got away from even giving them IVIG. Some of them have, because you need to give very high doses of IVIG, and everyone cannot afford that. Now, when you use steroids, remember that giving a pulse for 3 days is not enough. You need to follow it on with 2 milligram per kilo oral steroids, taper and stop over 3 weeks or so. And then you consider the next line of treatment if this is not adequate. Prophylactic heparin is not necessary for everybody. Remember that D-dimer is a reflection of inflammation first and foremost. So in children who are going to be bedridden for a long time, who are high BMI, etc., you would consider giving prophylactic heparin. We don't consider it in all the patients. Now, if your patients, you're doing daily labs, you're assessing your patient regularly, however, despite doing all this, they are not improving. That's when you move on to considering your next biological therapies. Do they need an anti-IL-1 or an anti-IL-6 drug? This is a luxury that the West has because they have access to both. In India, we have only IL-6. So if your patient has a refractory macrophage activation, if your patient is showing refractory fever alone with very high CRPs which are not coming down, I would go for tocilizumab. If your patient is showing increasing coronary artery size, I would go for infliximab, which is an anti-TNF alpha inhibitor. So that's the way we would kind of take it. One more thing is IVIG in the older children. Generally, we give a ceiling dose of 70 to 80 grams, even in older children. You don't need to go for a 2 gram per kilo like we advise in Kawasaki disease.
Okay. Thank you, ma'am. Very nicely summarized. Now, as per the literature, and as we discussed, more than 75% of these patients, they need a pediatric intensive care support. So, Dr. Satish, so what are the key PICU issues you face in these children, and what are the different organ dysfunction you see?
Thank you. As the name suggests, I think it is something which involves the multiple systems. I would say kind of all the systems, but then the systems are not equally involved. I'd say the cardiac involvement is quite significant, which is actually which is making us talk about this disease more. Because about 80 to 85% of them have seen some cardiac involvement, which is not only myocardial dysfunction or coronary artery abnormality, or it could be just elevated troponin I or BNP also. So the other organ system involved is the GI tract. So as we said initially, that most of them, about 80-90%, present with abdominal pain, vomiting, and diarrhea. And the other thing which, as an investigation, we had looked at the hematological involvement, which is, I would say, it will be more than 75 if you look at it, because you will see in most patients having lymphopenia, thrombocytopenia. And about 70% have dermatological manifestations, including rash, conjunctival injection, and mucocutaneous abnormalities. We do see involvement in the sense we have some features of aseptic meningitis in about 25 to 30% of patients. About 10 to 20% have some liver involvement in the form of elevated SGOT, SGPT, and some of them have kidney abnormalities in the form of an AKI. But CNS, liver, and kidney, or even the respiratory does not cause major morbidity for these patients. Overall, they account about 20% of all the patients who have MIS-C. So significant organ involvement, which we are concerned mostly, is about 85. About 85% is about the cardiac. Next slide.
So, thank you, sir. So shock is one of the prominent feature of MIS-C. So Sadish sir, so what are the types of shock you see in these patients, and what are your specific management consideration, including the inotrope choice?
Shock, I would say shock is seen in somewhere around 50-60% of patients. Somewhere around 70% of patients are admitted to the PICU. Out of which, if you say total number of patients of MIS-C, 50-60% have kind of shock. And so what we see is two different types, but there is a kind of overlap also. One kind of, I would say, the predominant type what we see, or which is kind of seen in most patients, is a kind of vasoplegic shock with wide pulse pressure and kind of hypotension. These patients are otherwise talking, otherwise look well, but then if you measure the BP, it's kind of low. They are warm, flushed, have a kind of a bounding pulse, but an NIPP shows a low blood pressure. So most of these patients will need initial fluid boluses, followed by a vasopressor, which is noradrenaline. But if you look at them, most of them don't need kind of very significantly high doses. We probably will get away with about 0.05 to 0.1 mics per kg per minute of noradrenaline in most patients. We don't see, let us say, like high doses like we see in septic shock. And the moment we put them on steroids, these patients with shock, and their inotrope requirement comes down quite quickly. The other form of shock which we see is patients with LV dysfunction and CCF. But if you look at pure cardiogenic shock, there is kind of, can you go back 1 minute? Prof?
Yes, sir.
So if you look at the other kind of shock is about cardiac involvement, maybe is 50%, but if you look at only cardiogenic shock per se, is quite less, somewhere around 20% or so only. Next slide, please, sir. So what we tend to do is avoid fluid bolus in these patients based on the blood pressure. If the BP is low, we would go for adrenaline. If the BP is kind of maintained or is kind of borderline, we could even use dobutamine. But then, unlike a patient who is having a, let us say, only purely myocarditis or has a cardiac problem per se, an inherent primary cardiac problem, and has a cardiogenic shock, here using milrinone is kind of tricky, because most of them have some element of vasoplegia, and that could be worsened by milrinone. So I would suggest probably adrenaline or dobutamine, and then probably later, once the patient is stable and you are very clear what you're dealing with, then if there is only myocardial dysfunction, milrinone is actually a good choice. And if you see these patients, the recovery of LV function is also very rapid. And if I have seen, let us say, we have had about 5 or 6 patients who have had this kind of LV dysfunction, and by the time they are out of the ICU, most of their LV function, even those who had 15%, 20% EF, have kind of recovered fully by the end of their ICU term, and 100% of them have become normal LV function at discharge.
Okay. Thank you, sir. So, Jackson sir, so you have managed a good number of patients in your pediatric ICU. So what is the usual course of these children in the pediatric ICU, and how rapidly does the organ dysfunctions improve?
Okay. Okay, Rao. So after you stabilize the patient initially with your fluid, with your inotropes, you started steroids, IVIG. What we usually see is that almost all of them become clinically stable within a few hours of starting definite treatment. But then a small, most of the cases, length of hospital stays around 4 to 5 days. By that time, we are able to shift the child to ward. And in a small subset of patients may have persistent LV dysfunction even after correction of shock. After maybe 2 or 3 days, they develop respiratory distress, sometimes requiring NIV. that we have seen in some of our cases. And the sinus bradycardia nowadays commonly being reported. Many of our patients also we have seen sinus bradycardia occurring during recovery. And when we treat them aggressively with maybe high doses of methylprednisolone, maybe that's the reason. I don't know. I'm not very sure. Some of them have hypertension, and some of our children had hypertension and encephalopathy requiring treatment in the PICU again after some time. And some of our children also had deep vein thrombosis. And 2 or 3 cases with deep vein thrombosis had RT-PCR positive for COVID also. So we don't know whether that is related to this. But what we do now is in children having severe LV dysfunction, we always treat them with prophylactic enoxaparin, all children, until we discharge the child, or maybe for a week during our PICU stay. Rauf? Next slide, Rauf.
Yes, sir. I'm moving to next question, sir. So, Dr. Suma, so you have been on the front run for spreading awareness about this disease for last many months, and you have helped many pediatricians and assisted them in managing difficult cases. So, what we were discussing so far was the usual presentations or the conventional presentations. So, what are the unusual presentations of MIS-C which you have come across, ma'am?
Yeah, so that's the thing. Again, being MIS-C, multi-system involvement, you can get very, very unusual presentations. I think it's picked up quite easily when there is a classic incomplete KD type presentation with or without shock. The problem comes when you have predominantly an abdominal presentation. So in the last 2 weeks, we've had a patient who presented as an acute intussusception with extremely high fever, extremely high inflammatory markers, and a failed, initial reduction, and therefore went for surgery. After surgery, the child was sent to a pediatric surgeon straight away. After surgery, the child was still not improving, and that's when we came to see. We saw the whole story. Immediately assessed, took a history, realized this is MIS-C, and then when we treated her as a MIS-C, she got better in no time. So, appendicular mass, similar story. It may not be in this season. Every appendicular mass you see may not be the standard appendicitis. It could be a MIS-C scenario. So think about it. Patients who present with neurological features, so seizures and encephalopathy, can be the overriding feature. We had our DMPG who just passed out. He went to a hospital and began career as a rheumatologist, and got called about a patient who presented with high-grade fever and a creatinine of 6. And he suspected whether this could be MIS-C, called me up, and I told him, and he just gave her steroids. And she improved beautifully. And this was a MIS-C who presented predominantly just with oliguric renal failure. Then pancreatitis, this is a very sad story. This is a child we lost. A boy who presented with toxic shock, fever, and jaundice, renal failure, and pancreatitis. He was diagnosed as leptospirosis initially and managed in that manner. But by the time he came to us, it was a bit late, and we were not able to save him. And also children who present with extremely unusual rashes from what we normally see. There have been patients who presented with gangrene. There have been patients who presented with much more widespread and different kind of rashes from what we usually describe. So there are so many other presentations that can also happen. But remember the general timeline. A child with very high grade fever, with the multi-system involvement, very high inflammatory markers, think of this possibility.
Yeah.
Now,
so thank you, ma'am.
Yes.
Yes, ma'am. Yeah, so Jackson sir was mentioning that most of these patients, they need a very short PICU stay, and even the hospital stay is not very long. And so now post-discharge, how do you follow up this patient, and what about how frequently do you screen the echo, and what are the prognosis, the short-term and the long-term based upon the available evidence?
So the short-term prognosis, basically you're looking at, your period just prior to discharge from the hospital. So the earlier you diagnose and start the immunomodulation, the much better the child improves, and you get a very good improvement overall. So the critical management of shock, the critical management of the cardiac dysfunction, all that is very, very important. And generally, once you start the treatment, you find that the ventricular functions tend to improve and proceed to normalization if treated early. ECG changes tend to normalize. The sinus bradycardia he mentioned is possibly also a side effect of the IV steroids that we use. IV methylprednisolone can sometimes cause a sinus bradycardia. In 2 patients, we had to actually give them orsipranilin for a space of like 2 to 3 weeks, and then that reversed and we could stop it. Most of the coronary abnormalities we've seen do need close serial evaluations. So we initially do at diagnosis prior to discharge. Then if it is a very significant dilatation, maybe a week later, otherwise 2 weeks, 6 weeks. And most patients were able to stop aspirin by 6 weeks. And almost everyone, I think, were able to stop by 3 months. Those who had coronary dilatation. The majority of children seem to be resolving nicely. Now, renal failure, seizures, pancreatitis are the more poor prognostic features that we need to watch out for, and we need to be careful. Overall, the mortality in the acute stage is very low. So far, reported across the world has been something like 0.2%. And again, looking at the same thing, this outlines what we see in the cardiovascular setup. So in the initial phase, you might find about half of them seem to have abnormal echoes, 30% have abnormal ECGs, and 5% can have a very low ejection fraction, below 30%. And many of them, the aneurysm rate was only like 8%, with significant coronary dilatation in 7.6% and mitral valve regurgitation in 3.1%. But most of these, majority of these patients do tend to resolve, especially if you diagnose early and treat early. The next slide. This is from a follow-up of some 580 patients from America. Next slide. So the long-term sequelae again are essentially the load is borne by the heart. So if they've had severe myocardial injury, it could lead to myocardial scarring, and that could predispose to long-term arrhythmias and cardiac dysfunction. And I think now in the US, they are having they are facing this problem. They are seeing children with MIS coming back with arrhythmias and some mild persistent cardiac dysfunction. Then coronary abnormalities may result, of course, we know that in aneurysms, but the incidence of this seems to be much lower compared to Kawasaki disease and what we've seen so far. And however, the important thing is it's not only the heart, even the other systems that are affected, though the majority of them tend to get better in the short term itself, they will need us to keep an eye on them if they have not completely recovered.
Thank you, ma'am. Yeah, it was nicely summarized. So, Jackson sir, so you have a good experience managing these patients. So, can you give a brief account of your IMC code experience and present your data?
Okay, Rao. As I mentioned in the beginning, I think we have reached the peak of, the epidemic now, I think, the pandemic. And this data, actually, I collected 3 days back, and we get at least 1 or 2 cases getting admitted in our PICU every day now. The number has crossed 50 now. And that's our data with most of our cases male 68%, and with a mean age of 7 years, and almost 70% above the age of 5 years. And we had only 3 children, about 6% infants, and about 10% of cases were RT-PCR positive. We had 2 deaths also, 2 of them having a refractory shock, and the children died. KD-like presentation was there in 11, and typical myocarditis, Mis-C, like 36 children. So, And the commonest symptom other than fever was there in all cases. And GI symptoms in almost all of them, like 96% had, then almost 70% had shock, conjunctival congestion in 66%, all those. And then CNS symptoms, about 20% of them had mainly irritability and lethargy. That's what we have seen. One child had seizures also. And another thing, almost a third of these children had ECG abnormalities. Peculiar ECG abnormalities we have seen, like sinus node dysfunction, junctional rhythms, abnormal repolarization, like T-wave changes, T-wave alternance. Can you go to the next slide, Rav? And as per literature, you can see that almost 20-30% of them have comorbidities like asthma, obesity, and other underlying problems like immune deficiency and all that. I mean, leukemia. But then we didn't have many children with comorbidities, except for 1 or 2 children with obesity and asthma. And another important point that we have noticed, I think it's there in the literature also, like Satish also mentioned that, like many of them, even with profound hypertension, have normal sensorium maintained almost towards the end. Like, and I think there is some similarity of this with the dengue we had. Many cases for dengue we had severe shock, hypertensive shock, but then the sensorium is maintained. And probably there is an element of capillary leak also in these children. I don't know. I'm not very sure about the pathogenesis. And as I mentioned earlier, second or third day, we have seen children having respiratory distress related to pulmonary edema. Urticaria angioedema, we have seen in 2 or 3 children. Subcongenital bleed, we had 3 children with subcongenital bleed, and but then we have not seen any increased severity in children presenting with subcongenital bleed. And last 2-3 months, we have seen an increase in number of diabetes DKA getting admitted in our hospital. 2 or 3 children with Mis-C had DKA as one of the clinical features. And false positivity for rickettsial antibody, leptospira antibody 2 has seen, and that I think underlies the importance of you taking the sample before actually starting IVIG. But even if you have taken samples, they have this. We got rickettsial antibody positive, but not very high, but in OX2 and 1 in 60. But then this we have to keep in mind that there can be false positivity of this. ECG abnormalities are already referred to. Renal involvement, we had 1 child with severe AKI presenting with features of a glomerular type of acute kidney injury with granular cast in urine, plenty of RBCs, and hypertension, and all the manifestations, but that child recovered. And surgical emergencies, very common presentation nowadays, and many times they present in the pediatric surgery ward, and then they say that there is something that is unusual about this case of appendicitis. We had pancreatitis, appendicitis, orchitis in 5 of our children. So orchitis is a very common symptom, I think, throatal pain, but they all these improve dramatically once you start steroid or IVIG. And you can see this subcongenital bleed, but then no correlation with mortem with the severity of the illness we have seen. Next slide, Rao.
Yes.
Can you go to the next slide, Rao?
Yes, sir.
And this is a very common abnormality that we see nowadays, this SA node dysfunction. P waves, you can see in some of the complexes, P waves are not there, junctional rhythm is there. Wandering atrial pacemaker like abnormality also have seen. And T-wave abnormalities also, like prolonged QT interval, and T-wave alternance is there in the second ECG. These are different children. So almost 30% of our cases have ECG abnormalities also. I think that's it, Rav.
Thank you, sir. Yes, thanks. So, Sadiq sir, can you share the Aster experience briefly?
It's similar to what the sir has told. I think I've kind of added the Aster CMI Bangalore also to our data, because Dr. Sagar Bhattad, our pediatric immunologist based in Bangalore, is who helps us with these cases. So out of these 25 patients, if you look at, like, both our centers are more or less the same. And compared to what sir was telling, because we have not had so many patients, we have not had orchitis, We have not had a renal involvement at this point of time. The rest are more or less the same. They have mostly fever, and most of them had a KD-like picture. Like about 80% had fever, rash, conjunctival injection, and oromucosal changes. And about somewhere around 60% hypotensive shock, so about 60-70% were in the ICU. About only about 30% were treated purely in the wards, and 90% were serology positive, and 20% of them were PCR positive. We had about 30% kind of having prominent or dilated coronaries, but then all of them have had their coronaries kind of normalized with our follow-up. Like some patients who have had kind of dilated coronaries have become normal with a follow-up of about 2 months or so on steroids, basically. So we've used IVIG in most patients 90%, and those who were sick and were in the ICU about 60% with shock had received steroids also, and none have received immunomodulators. And if you look at peculiar things which we had or unusual things, one child who had recovered and went home on steroids came back after 2 weeks with bilateral hip synovitis. We actually started tapering the steroids, so we had to go back to the original dose, and we had to taper a bit slowly. His CRP, everything went up after 2 weeks. Then there was a child who presented with all features of MIS-C with a CRP of somewhere around 300, 350, and also the severe ARDS. Luckily, he didn't have a myocardial dysfunction or shock, so that we were able to pull him through out of the ARDS. Our outcomes, like all have survived, and we have not used any immunomodulators also in any of these patients.
So, so this is a final question for panel discussion. So, Dr. Suma, so what is your advice for a general pediatrician in OPD regarding how to recognize, or rather how not to miss in a busy OPD?
I think in today's scenario, any child who presents with a high-grade fever, this should be one of the possibilities in your mind. So then look at the child further and see clinically how they are. So if there is high-grade fever with systemic inflammation, clinical plus lab, and a multi-system involvement, it can even be a single system which is severely involved. And then you look for a possible link with COVID. If these are present, please consider MIS-C, and then we need to investigate the child appropriately, like how we discussed previously. Look at look at all the acute features, look at the specific lab tests. So here you have this thing where you have suspected MIS-C. In the lower branch, you're seeing children who have a atypical KD type presentation with high-grade fever and a COVID link. These patients, you do all the tests that we recommend. Or if you have a patient who presents with shock of unclear etiology, then if you think that they've got a contact with COVID, then again you go for the whole lot of investigations. If, however, they don't fall into either of these categories, where you have a fever, you think they might be, then you will do tired investigations. So you look at CBC, CRP, ESR, and a COVID-19 testing with antibodies. And if on this further thing you strengthens your suspicion, then like if they have lymphopenia, low platelets, neutropenia, hyponatremia, low albumin, etc., and they have a possible COVID-19 link, then you go for the rest of the investigations and you assess this child and treat like an MIS-C. Like Dr. Jayakrishnan said, sometimes we might over-diagnose. It is possible. But you must think about it, because the recovery from these patients when they are picked up early is simply amazing. So remember that the clinical phenotypes is a spectrum. You can have MIS-C without overlap with COVID-19 or Kawasaki disease. So these are the ones who mainly have abdominal features. They can present with CVS and GI features plus or minus some others. Shock, cardiac dysfunction, markedly elevated CRP ferritin with a positive SARS-CoV-2 serology plus or minus an RT-PCR positivity. You can have MIS-C with acute COVID overlap. So these patients can have respiratory involvement plus systemic inflammation. And this is the group which has the highest mortality rate noted. Then you can have MISC overlapping with KD. So these are usually the younger children. They have many features of incomplete KD. And these patients are usually positive on serology and negative on RT-PCR. The main story here is think about this. In a current pandemic, we are seeing a lot of these patients. Unless you think about it, you miss the story. So
Okay.
this is again to
Thank
further
you, ma'am.
And I think one more thing.
So we have completed.
Just one thing. Any pediatrician who's feeling vulnerable in the periphery, you think you might have a patient, you can be free to call all of us here, and we are all very happy to help you on the telephone.
Okay. Thank you, ma'am. So nice of you. We have concluded the questions for the panel discussion. So we have many questions in the chat box, and most of them have been answered by Suma madam already. And I will take up a few questions. Ajay, how much time we have left?
15 minutes will take for questions.
Okay. So I will take a few of the questions. So one question is about sodium and albumin. So Dr. Sadish, so how many cases you see hyponatremia, that is symptomatic hyponatremia, and how many cases you see hypoalbuminemia, and do you use albumin infusion during the resuscitation phase or during the de-resuscitation phase?
We do see patients with hyponatremia and hypoalbuminemia, but they are not very, I have not seen very significantly low hyponatremia, which cause problems. But then it is actually helps to prognosticate in those patients. It is said that hypoalbuminemia or hyponatremia is a poor prognostic marker, or the patient can behave badly, or they can have a sick presentation, or they can worsen. That is an indicator. It's useful in that sense. So if you do it once and they are reasonably normal, we don't keep repeating it. But then if they are extremely low, obviously we should treat. But using albumin for fluid boluses, I don't think it is necessary, because we already know that in any form of shock, septic shock or any kind of shock, we are not going to use albumin upfront. We're going to use crystalloids. So yes, they are poor prognostic markers. If they are significantly low, I would say the hyponatremia, yes, you should treat it. But I haven't seen any very low numbers.
Okay. Thank you, sir. Jackson, sir, next question is about the antibiotic of choice, or I think what is the empirical antibiotic you start in a case of suspected MIS-C?
As we discussed in the beginning, they present with hypotensive shock most of the time, and we are not very sure whether this is septic shock or not. So we empirically treat all of them with what we do in our PICUs. We start them on ceftriaxone and add vancomycin also. We have not suspected TSS so far in any of our children. If we had suspected that, we would have maybe started clindamycin. So in the initial choice of antibiotics in a child presenting with hypotensive shock would be ceftriaxone with vancomycin in our unit. Till the cultures come, and once we get the cultures negative, we stop the antibiotics.
Okay. Dr. Suma, there is a question regarding the discharge medication. So what are the medications usually we give to these patients on discharge? I think already you mentioned, but because it's important, you can briefly describe it once more.
I would presume that when a patient is fit for discharge, usually they are afebrile, their inflammatory markers have come down, and the main systemic issues are come under control. So at this point, most of your cardiac support, all that would have been weaned off and stopped. So it would mainly be, if you have needed to use steroids, then steroids with a weaning plan should be specified at discharge. That will still remain there. If your patient has any antihypertensive on board, or very rarely, like we had to give orsitronelin for a couple of patients, I would think these are, and low dose aspirin for in those patients who have coronary enlargement. These are the only drugs I can think of that will be required at discharge. Of course, if you've had a patient who's had seizures and is continuing on antibiotics, then that will also be continued.
Thank you, ma'am. There are questions about low molecular weight heparin and the incidence of orchitis, but I think that was well explained during the discussion, ma'am. I think, Dr. Ajay, if there are no more questions, I will hand over the session to you.
Madam, I would like to ask one question to Suma, madam. Madam, suppose I am a pediatrician walking in the periphery, and I get a case of suspected MIS-C. It came with high fever, and probably I have some CRP and other things in my hospital, from which I could make a clue that it is MIS-C. But the hospital, and I want to shift the child to a tertiary center. The child is still not in shock. How much time will I get before the child usually? And if I am shifting, should I give the first dose of steroid before shifting? And if giving steroids, which steroids do you prefer? Dexona, hydrocodone, or methylpred?
Okay. So I think it depends entirely on the clinical phenotype you have. And if you're suspecting that the child has a MIS-C, if your child is not already in shock, then you can actually, and it's not going to take a long time to reach the next hospital. You can ring in advance, let them know the patient is coming, and you can just send the patient as they are. If your child is already having borderline hypotension issues, etc., it's better you stabilize before you send the child, or you make sure that the child is retrieved in a safe manner to your tertiary hospital. You can start steroids in these patients. Depends. I mean, the patients who present like an incomplete KD, these patients we actually prefer IVIG for them as a first choice. But if you're giving steroids, I would prefer to give them methylprednisolone. The dose of methylprednisolone in these patients does depend on the clinical presentation. If your clinical presentation is with shock, with macrophage activation, they do need the higher dose, so 30 milligram per kilo kind of dose. But if your clinical presentation is not with a significant shock, or if you don't know exactly what the thing is, you can give a lower dose also. Many younger patients have got away with 5 milligram per kilo or 10 milligram per kilo boluses for the first 2-3 days. I think it would be good. You can just, if you ring the hospital you're transferring to, speak to the doctor there whom you're transferring to and explain the situation, and then transfer the child. They will probably have a better dialogue going, and that would help you rather than just sending off the patient on their own in that sense. I hope I've been clear. If you can start IVIG, some of it before going, that's also fine. But it depends on whether you have monitoring facilities and all that. So it might be better to actually get these patients across to the tertiary hospital straight away.
Because I was asking this question, ma'am, because sometimes we tend to get patients in shock, but when they are left from the peripheral hospital, child may not be in the initial part of shock. So
I think the thing is, if your patient is in shock, resuscitation is the most important thing. So give them fluid, give them, start an inotrope, and you can start the steroid as well at the same time. All that is fine. But resuscitation is still the most important part.
okay, thank you, ma'am. We will take question from the senior. We have a lot of senior pediatricians here. I think everybody can unmute themselves and ask questions if they want. Shashen, sir.
Thank you, Ajay. That's an excellent session. Thank you for the panelists, Dr. Suma, Dr. Jayakrishnan, and my dear Rauf. I think the one point I want to drive in is clinically you can diagnose this multi-system involvement. If no patient will come on day 1 of fever. Wait, they'll be seeing periphery and then coming back. The subconjunctival hemorrhage and bradycardia and shock. And we have recently 3 patients came subsequent days from the same locality in Alabama. And we could clinically pick up the myocarditis, S3 gallop rhythm, and that was picked up and that was managed that was managed in the ICU. The bradycardia is a very predominant finding we had in all the 2 of them. One of them went to IMCH to Jayakrishnan. And as you said, the thrombocytopenia, After a week, it comes to thrombocytosis. And again, after a week, patient shows some of the signs of Kawasaki disease. This is also that we used to see. So the follow-up the patient from discharge from ICU and follow up the patient, the blood parameters and the clinical recognition of these things will add to what Dr. Suma was telling about, I mean, the shade with Kawasaki disease. The coronary problem also, of course, you have to go repeatedly. Recently, we had one patient who had left ventricular hypertrophy, concentric hypertrophy of the left ventricle. But we never had, I think, Rao, we never had a hypertension. Jason was studying about hypertension in these type of patients. We never had, I think. All of them were in hypertension and shock and acute kidney injury and all recovered. Absolutely, the very fast recovery within 24 to 48 hours by giving enough of IV fluids and then steroids and IVAG. So I think this is something which we should work on. I think all the three experts are here. You should make a registry type of thing for the whole state, and we should evolve. Most important is to cut the cost of treatment. I think it's a sharing of information from all the centers may help us, because IVAG is a terribly costly affair. Steroid, of course, you can make some manipulations and manage. So the affordability of treatment is very important for our patient. And there are certain pockets from where all these patients are coming. And Calicut has become a hot spot for COVID-19 now, because it is always on the increase in the rest of the states, just like Cochin. Cochin is also you get a large number of patients with the positive rate, and the test positive rate is also very high in this region, and it will last long. I don't think it is going to subside. So you should suggest modalities for simplifying the diagnostic criteria as well as the investigations and the treatment. Whatever information we get is already known, but how to simplify it and affordable type of treatment is essential for people from our state. Thank you.
Sir, Ajit Kumar, sir, HOD Pediatrics.
Yeah, thank you, Ajay. It was a wonderful session. And in between, there was some connectivity problem, so I couldn't. But it is a need of the hour. Like this discussion was really at the need of the hour. And it was Dr. Mohandas and me who had suggested that all pediatricians should have this information for early identification of COVID-19, post-COVID-19 syndrome like Mis-C, and so that they refer early to centers where it can be treated. So some of the things that the experience was so huge that we had around 50 patients with Mis-C, and it's growing day by day. The number is growing, and we are we are conducting a study and also follow-up study. And Dr. Jayakrishan, Dr. Geeta P, and me are part of the study of this Mis-C, and we are having a follow-up clinic for Mis-C patients. And so maybe time will tell what will happen the long-term follow-up of these patients with Mis-C. My question to Dr. Suma Balan, all the panelists were really excellent. I mean, is it Mis-C very only like can any other viral illness like adenovirus, can they have a similar Mis-C-like presentation?
I think so. I mean, I think that we are seeing so much of this now because we are a pandemic. We have so many cases of the same infection. So we are seeing patterns and we are picking up. But if you see dengue fever, every year it presents with, there are patients who present with severe macrophage activation syndrome. And that is a similar kind of immune dysregulation again, post-dengue. Similarly, mycoplasma is an infection that has, the extrapulmonary features of mycoplasma are all immune mediated. It can present with stroke, it can present with thrombosis in a number of places, it can present like a vasculitis, it can present in so many manners. So there are, I think it is possible for many infections to trigger the immune system and cause inflammatory changes like what we are seeing here, and immune complex and vascular and other manifestations. However, when we are in a pandemic and we have lots and lots of cases of one particular infection, it is possible that we will see similar patterns of disease occurring all at one time to create a syndrome.
Because we had just before the
Yes.
pandemic, we had an adenovirus clustering in our.
Actually, if you go to this definition, the first, I had a patient in March early this year who fitted MISC in every single possible way. And that was early March when we didn't really have that many patients in Kerala. And we treated her with immunomodulation and she got better. And I didn't think twice about it after that. But subsequently, when we started diagnosing MISC left, right, and center, I thought about that girl and realized I had treated a MISC-like syndrome in her, only we don't know which bug it is. That's all.
Yeah,
So
one of our earliest patient is landed up in pediatric surgery as pancreatitis, and that's what one of the earliest. So I think pediatric surgeons should also be here to be so that they should be aware of because one of the most common presenting complaint is abdominal pain, severe abdominal pain, pancreatitis like illness, and they may sometimes do a laparotomy. So thank you very much, Dr. Mohandas and Ajay, for including this topic for the awareness, and all the panelists were really excellent. And I congratulate Rauf for because taking the initiative and making moderation, because it was the first paper. I'm really proud of it. First paper on all of Asia on MISC. We really are proud of it.
Thank you, sir.
Thank you, sir. Dr. Shaji Thomas John, sir, the past IAP Kerala person. Sorry.
Well, I must thank the IAP Kozhikode for taking up this topic because it's very relevant at this juncture. Now, what we have learned is that this could be a mimic of various other diseases, just like an adenovirus or a host of other diseases. But under the present context of the pandemic, we have to keep our minds open. So it's a question of sensitizing is and keeping our minds open to find out the possibility of this because we cannot just afford to miss it. We already talked about the judicious use of investigations. A host of investigations that can be done, but we must consider the patient also and what to be done, a clinical presentation with the absolutely essential investigations. And what I would suggest is better to overdiagnose it and overtreat it rather than miss the diagnosis and lose the child. So that may be a controversy in that aspect of over-diagnosing and over-treating it. But I think at this juncture, it would be better to over-diagnose and over-treat it rather than lose it till we get more evidence on about this disease and how things can be done. Of course, treatment too is with IVIG, as Dr. Shashian sir mentioned, is expensive. We got to think of those also before starting these things. Anyway, thank you very much. And it was really wonderful. And I'm sure it's been informative to all those who were listening to it, because barring the few hospitals, I think it was essential to sensitize the whole pediatric crowd on this topic. Thank you.
Yes, sir.
Thank you, sir. Mohandas, sir, shall we? So please unmute.
This fever in children could be due to this problem, and many of them will be having this cardiac dysfunction, and at the same time they may not be having much symptoms. So you should be very careful in making them. You should not make them exert. They can suddenly deteriorate. So that is one point which I have to share. They should not be climbing steps and all. Dr. Geeta P, any points to mention? We'll stop in 1 or 2 minutes. Geeta? She's not here?
It's here.
Madam, please unmute. Because I think we have covered all aspects. Yes, sir.
Okay. In that case, can we, Ajay?
Yes, sir. So, thank you, everyone. First of all, I would like to thank our panelists, Dr. Suma Madam, Dr. Sadish sir, Dr. Jayesh sir, and my colleague Dr. Abdul Rauf for taking up this wonderful session relevant in this scenario. So it has been a confusion for everyone how to deal about it. So I think this would have given an idea into like how we can proceed, especially when you're working in the periphery, especially if you're working in small hospitals, and especially when we go to critical care level. So and also excellent questions from all the senior members of IAP Kozhikode, Dr. Shaji sir, Shashin sir, and everyone. And also I would like to thank Mohandas sir and our HOD Pediatrics Ajit Kumar sir for suggesting this topic, which is quite useful for all the pediatricians. A lot of senior members have joined, Latif sir, Geeta madam, everyone. So I thank everyone for staying so long. Thank you, everyone.
Thank you.
Okay, sir. Good night.
Okay.
Thank you. Thank you.
Good night, everyone.